Hi, I'm Stephanie Shelton, and this is Conversations on Health, How We Get There, episode 30. Perhaps the hottest, most divisive topic in all of healthcare is obesity, which in the U.S. appears to have stabilized at 40% of adults. Is obesity a disease or a lifestyle result? How does it affect overall health, and what diseases can it cause? Who should take the expensive new GLP-1 drugs? And perhaps the most divisive issue, who should pay for those drugs and how? Get ready for a great conversation with tons of usable information from my guest, Dr. Naser Gharaibeh. He is the head of the Valley Health System Center for Weight and Wellness in New Jersey. He is a board-certified doctor in obesity medicine, as well as endocrinology, diabetes, metabolism, and internal medicine. Naser, thank you so much for coming on the podcast. I really appreciate it.
Thank you for having me. I'm very excited about being with you today.
We're talking about obesity today, and it's like probably, although maybe it doesn't merit it, but it's probably the hottest topic in medicine in terms of those of us who are the patients. Would you tend to agree on that?
100%.
So maybe you could explain, because a lot of us grew up and we just used a three-letter word to describe what is now obesity, and it wasn't considered a disease. What exactly is it? Is it truly a disease? Or is it, as many physically fit people seem to think, just kind of people who won't get off the couch?
So obviously it is 100% a disease. It's a chronic disease. It's a disease that comes and goes. So it's a relapsing, remitting disease. If you look at the definition of obesity, according to the Obesity Medicine Association, it's a chronic, relapsing, remitting disease that's complex, that has a neurobehavioral component to it. So it's not just, defined by being quote-unquote fat. I always tell patients we never say the F word in the clinic, right? So that's
why I didn't say it.
I know, but I feel like we have to have the courage to come forward and talk about the root cause, as you mentioned, Stephanie. This disease has been caused not just by physiology, but also from the society. It's the disease that you wear on the outside. Again, it comes and goes. It's complex. It's relapsing, remitting. So sometimes the disease is controlled, you lose the weight, and sometimes your health-related issues are uncontrolled or in control of your weight. So you take a medication, you regain the weight. Or you go through depression, you take a medication for it, or even the depression itself, it can cause exacerbation of the weight problem. It is defined by having excess body weight, but the more accurate definition is defined by having excess body fat. So again, these patients are not fat, they have excess body fat. And every patient with obesity is the same. And I'm not saying every obese patient is the same. Every patient with obesity is different. They are not the same. It could have a genetic background as the primary problem, or it could be an environmental problem. For example, someone who has chronic pain, joint replacement, fluid retention, cardiac problems. All of these issues can result in excess body fat, but also patients with behavioral problems, such as patients with binge eating disorders and many other eating disorders out there.
So it sounds like before you can do anything to help a person with obesity, you almost have to be a psychiatrist, as well as do the blood tests and all the rest of it.
Absolutely. You have to really tease out why the weight gain has happened to start with, and why the patient wants to lose the weight. Because this is another issue. Not all patients come to the quote-unquote weight management clinic, which I hate the term weight management clinic, because this is not about the weight. There's a lot of psychology involved, as I mentioned. And the root cause is the kind of one of the driving forces. But also, why do you want to lose the weight? Which is also a driving tool to help me navigate how can we help patients, take care of the weight issue and achieve, good results in terms of their health. This is not about the weight on the scale. And this is not just about the excess body fat. This is about being in control.
So how did we get here? I mean, I believe the latest figures are 40% obese and as much as 20% in young people, teenagers and children. How is that possible? And when I was growing up, which granted is getting longer and longer away, but I don't ever remember seeing anybody, maybe one person occasionally, but certainly nobody in my school, nobody in my high school. How did it happen?
It's complicated. To start with, 50% of our BMI is inherited. It's kind of genetic. You get that from your parents. But the other 50% is the one that we can control. It's your environment. So environmental design is essential. So for example, the portion distortion is a real issue. Again, portion distortion. Going, to dine and like go to different restaurants, I was shocked by how large portions are. So if you compare the burger in 2025, the size of a burger, when you compare it to actually the size of a burger or the amount of calories in 1980, not long time ago, just 40, 35 years ago, the burger was at least 60, 70%, smaller. So same thing applies to a slice of pizza, these huge slices of pizza. And not only that, we got very creative in the 1970s and 80s. Everyone blamed the kind of a little bit higher prevalence of obesity on fat, right? And then we started doing is we started creating fat-free products, fat-free milk, right? And then we had to do something with the excess fat we were getting or extracting from the milk, right? And this is when we started having a lot of cheese. And then what do you do with the excess cheese? You make cheesecake. You make pizza stuffed with cheese. So now you have much more calories, much more processing, okay, less healthier options. And then in the early 2000s, maybe we started figuring out it was not actually the fat. It was carbs. So carbs were driving, the food intake in the food industry. And not only that, it's not just about the kind of the carb versus the protein versus the fat, but rather it's the processing. So when we process food, we're actually dealing with a lot of, addition of chemicals, and many of these chemicals are not just high or result in higher caloric intake, but it results in a kind of consistency in food where actually you crave for more. So it's
there was something about that the food, the big food like the Nabiscos and the big food companies started putting in products that appeal to a particular place in your brain that people want to eat more. That really caused the problem because we all know you can't eat one potato chip.
Yeah, exactly. Yeah, so there are hedonic centers in the brain. There are centers in the brain that perceive the hunger cues. And then hunger cues can be, the signals that will give you the higher caloric intake so that you can meet your needs, or also can be hunger cues to express emotions or satisfy your emotional needs. And these are the ones that result in emotional eating and other unhealthy behaviors that can lead to disordered eating. And we're not saying eating disorders, disordered eating.
Yeah.
Right? So all of these small habits you accumulate throughout your life, where you continue to consume processed foods, not as much, whole foods, bigger portions. And also we're social creatures, right? So we kind of try to socialize through not just, talking, but also through drinking, but not through drinking, but also through eating. So it's very complex.
Yeah.
Neurobehavioral, but also it has to do with the environment.
Um, I think I'm going back to the thing you said about emotional eating, which is the one thing that I think every one of us can identify with. We all go through periods of emotional eating. When you're upset, when you're pressured, when you don't want to start a project. I mean, I can tell you the times that I go and just keep eating, and I am not fat. um, and oops, I used the word. And the thing is that some of us, when we have gotten control of that emotion or that situation passes, just go back to being our normal selves and eating our normal food, and other people don't. And again, is that inherited or is that something that develops?
It's something that, for the most part, it's something that develops. So there is a difference between emotional eating or eating disorders, which is obviously more complicated, and obviously the social. There is a social aspect to things. So, for example, people who have an Italian or Middle Eastern background, right? Many of them, they consume actually large amount of calories, and this is the way they were raised. I'm from the Middle East. You like love is defined by providing more or feeding more, right? The mom is always like trying to push the little kid to eat a little bit more, and this is kind of a driving force.
Mm-hmm.
So these are the things that are kind of subtle and small, and you develop, but they are also environmental. But the biggest difference or the biggest kind of factor I always look at when it comes to disordered eating versus eating disorders is the kind of how much pressure that behavior is putting on the individual. So if it's causing a lot of guilt, avoiding eating in front of others, not being kind to yourself, or what we call internalized weight bias, having a very negative self-image about all of these behaviors and about why you have gained the weight, defining yourself as someone who's not very healthy. All of these signs are signs of, advanced complex eating disorder, versus if someone is cracking jokes about how this is how I am, and like this is how we are in the family, this is how we were raised, that's not necessarily right, and that results in excess caloric intake, and obviously results maybe in the same end product, excess body fat. However, it's not as detrimental to the emotional and neurobehavioral health. Again, not all patients with obesity are the same. You can have two people who have the same body mass index, the same weight, the same actually obesity or weight-related morbidities, but how much damage is doing on the outside, on their brain, on their self-confidence, that's a significant factor we need to look at as a community, as a population, but also as physicians.
All right, so now let's go to the magic drugs, the GLP-1 drugs. A lot of us, and I count myself among them, I'm a former marathon runner, and if I hadn't screwed up my knee, I would still be running distance. A lot of us just look at this and say, these are expensive drugs, no matter what our insurance is, whether it's private, whether it's Medicare or Medicaid or whatever. And ultimately, we're all going to pay as we do for any expensive drug that an insurance company covers. Do I want to be paying for what I still see as somebody else's inability to just deal with their own life? And that may be very unfair and very elitist, perhaps, but I was a fat kid. I started out fat, and I dieted my whole life until I started running, and then it was magic. And, you know, people like me, and there are lots of us, still have trouble accepting this concept that it's a disease and people can't help themselves. And how do we deal with that? And it's a fairly large segment of the population. So how do we deal with that? Because we have to think about the money end of it. If they cost nothing, nobody would care if you use them.
Mhm.
And we have to think about the actual medical and health aspect of it and what you get down the road if you prevent somebody from getting a heart disease or having fatty liver or whatever else can come from obesity. How do we balance this and how do we convince people that there's a need to balance it?
Yeah, so this is a great question, actually, because it's not kind of talking about one person at a time. It's talking about the population. This is about also the cost of care, right? So the answer is simple. Yes, we do have, as a society, we do have to pay for these medications. Why? Because it's the responsibility of the society as a whole to take care of this issue. And why is that? Because it's a chronic medical condition. It all goes down to the first question you asked me. Is this a true medical condition? Why don't we, get these questions of people saying, why do we have to pay for medications for diabetes? Why do we have to pay for, conditions like breast cancer? Right? Do we get these questions? We don't.
No.
Why? Because we think, including, the medical society, many physicians, they do not believe that, obesity is a chronic disease. And we don't want to see it. We turn a blind eye. We just tell the patient, exercise more and eat less. Well, that patient has severe, fluid retention or severe knee pain. How do you expect them to move more? Or maybe this patient has a binge eating disorder. Or maybe this patient has disordered eating. They have sleep apnea. They have so many complications. Maybe they are severely depressed. How do you tell someone who's severely depressed, I just want you to be happy? Can we do that? We can't. We know that we can't. But we do this to patients with obesity. We keep asking the same question again and again. Like, why do we have to pay for it? Yes, we do. If we truly believe this is a true medical condition, then we have to find a way. And if there is a will, there is a way.
Okay. So I'll take that under advisement when I start getting elitist about exercise. So let's go back to the drugs. How do they work? And they don't work for everybody. Is that correct?
That's correct. Again, same way, not all patients with obesity are the same. That's why they work and the medications work differently, and then they may work for some patients, but not work for others.
Are they, just let me interrupt for a second. Are they all the ones that we have approved, which I believe are 3 of them now? Do they all work the same way?
So the newly approved medications, they work the same way. They're injectable medications. They're not insulin. They're basically given once a week for the most part, and they slow down the transit of food from the stomach to the intestine. They make you feel full easily, right? And that's why they commonly can cause a lot of gastrointestinal side effects, including also dehydration and rarely pancreatitis. But these are the newer medications, but we forget about the much older medications, including actually amphetamine and phentermine. So phentermine is one of the first medications approved, I think, in 1959 for management of obesity. It suppresses the appetite. It's considered a stimulant, very similar in structure to amphetamine. And this medication can increase energy expenditure, can actually a little bit improve the kind of the focus so it's a good medication for patients who also have or suffer from ADHD, but they are a great tool for patients who have binge eating disorder. Okay, so this is a very effective medication that, in my opinion, is underutilized. There are also other medications that can help reduce cravings or, block weight gain from medications, such as metformin, which is an underutilized medication. So we try to look at what the kind of the individual characteristics of patients, why did the weight gain happen? And also the most important factor is not actually the diagnosis, but what we call social determinants of health. How much they can afford. Can they afford paying $200 or $500, or in some patients maybe they would pay $1,000 a month for the medication? So we look at all of these, factors and decide what's the best treatment option for that particular patient.
That, of course, you've raised the unfairness issue, which brings me back to everybody who needs it should get medication or any health care. And it's totally wrong, I think, many of us, to make it a money thing. And you mentioned that when we were first talking about care for this. If you need it, you need it. And you should be able to get it, and you shouldn't have to worry about, well, I can't possibly pay for it. And that brings back the insurance companies. I know that before President Biden left office, there was a plan to allow Medicare to pay for these drugs for weight loss. They pay for them now for heart disease and something related to that. But whether that will survive or not, there's no way of knowing that under President Trump. But bottom line, if there is a new drug and it can help somebody, and I don't really care what the disease is, that person should somehow be able to get it. How do we ever get to that point? And I will bring up one other issue, which is I've done a number of podcasts on how the health systems work in other countries, and the fact that everybody is covered. You pay for it through your taxes, but if you're poor, you don't. You get it anyhow. And they have the same drugs we do. I've never heard of anybody ultimately being denied a drug because they couldn't afford it, because it's paid for.
Yeah.
And we have a private system. We have a quasi-private, quasi-public sometimes system, but people still have to deal with this problem. How do we, I mean, it's right at the beginning of this for these drugs. So you as a doctor, how can you say to somebody that can be helped by a GLP-1 drug, well, I know you can't afford it, therefore you can't have it, your insurance company won't pay for it?
What we need is advocacy, obviously. Physicians have to advocate for their patients, but advocacy does not come, one hand cannot clap, right? So what you are doing is an example of advocacy. You are asking, intrigued questions, trying to understand why this is happening, right? And is it actually a true medical condition? I do not expect Stephanie to know the answer. I mean, that's why we need ongoing discussions, not just with physicians, but with patients who suffer from that condition, right? So rather than, blaming that on people and actually not having an open conversation, we need to be honest with ourselves and, ask, is this really, approach this with an open mind. Is this really a true medical condition? How does a patient with obesity feel? So that's number one, it's the mindset. Number two is the cost of medication. It's actually inflated significantly in the United States. I'm from Jordan. The same exact medication in Jordan, the cost of the medication, Ozempic, for example, it's less than $150. In the US, exact same pen is for $1,200. Of course, there is something wrong there, right? Because what we do in the US, we make the pie much bigger, and everyone has to, get part of that pie, whether it's the pharmacy, the insurance plan, or even the what we call the PBM. I don't know if that's the
pharmacy benefit manager.
That's someone who has nothing to do with the medication. They did not make it, did not market for it. The only thing they did, they negotiated a deal on top of everyone else, and then they take 40%, 50% of the cost of that medication that goes to them. So if we approach this or think about this as a public health emergency, as a low-hanging fruit where we can actually make a significant difference in the wellness, not the sickness of the population, then someone has to come forward and say, you know what, we need a new policy, we need a new way, and there is a way. I mean, there are ways around it. You can, as you mentioned, you can, like, maybe federally we can just buy. We did that for COVID, right?
Right, exactly.
Over the world. I mean, the federal government had control over hospitals. They were setting rules. They were like, okay, I want hospitals to, start programs tailored towards wellness, not towards, making programs for joint replacement or open heart surgery, right? We need programs for wellness. We need programs to address, the physical activity in the community. We need, walking paths for the community. We need better insurance coverage. We need pharmacist-led programs. We need wellness programs for the retired community. We need to focus on longevity. We need to approach the schools, right? There are so many, like, healthier. In the United States, pizza is considered a vegetable as an item, right? This is actually true.
Somebody told me years ago that if you have to eat fast food, pizza is the healthiest.
Yeah.
I firmly believe that.
So we all love pizza, but again, it's not about the pizza. People think, oh, it's the carb. It's deeper than that. It's the mindset, right? The mindset of wellness, the mindset, not the mindset of convenience. This is what we have in the US, the mindset of convenience. I want to park my car, at the mall. That's covered, just next to you can spend maybe 20 minutes, just looking for that parking spot.
Perfect space, yes.
Perfect space, right? Because you don't want to walk more.
Exactly.
This is what's all of that is, summarized by, the mindset of wellness, the mindset of growth.
All right, we could talk about this forever, I think, and bring in half the medical population of doctors and nurses and practitioners, and I think we'd all agree. Let me go back to the GLP-1 drugs, and can you explain to some extent, and again, going back to what you said, that each obese person is different, how do they work beyond just slowing down? Because there's been a lot of, they are now okayed to help heart health. They're okayed for other things other than obesity. There's apparently some kind of mental illness that they work to help, that goes along with the part of the brain that the pleasure part of the brain, in terms of eating more food that you like. So how do they work? And I know that, for example, I have a friend who decided to use one. She's a former nurse, a retired nurse. She got sick, like you said, with GI issues primarily, and ended up figuring out with her doctor to cut the doses in half and to slow down. Yes, she would lose more slowly, but she would still lose, and it's worked very well for her so far. So there are ways to deal with the issues that you spoke about in terms of some people having trouble with them, but how else, other than just slowing down that desire to eat more, do they work, and why do they work for some people and not others?
So this is a great question. So basically, they have multiple mechanisms of action. The main one is maybe gastrointestinal, which I mentioned, but also, yes, it works on the hypothalamus, the base of the brain, where your instincts and your appetite comes from. We have set points for our weight, for our sleep, for our sex drive, right? But also in that area, in the hypothalamus, for addiction, right? In that particular area, the medication works on suppressing, the signals that come from there. And that's why it gives a little bit of satiety, but also has been some early positive evidence it may help with addiction, right? So
yes.
addiction to alcohol. Just had a patient actually who had very heavy alcohol use. He came last Friday and was able to stop drinking alcohol. It worked like magic for him.
That's amazing.
Yeah, 100%. But then also it works on insulin resistance. Mm-hmm. So it reduces the amount of insulin we require to metabolize the carbs we eat. So if the patient is having issues with insulin resistance / prediabetes, or what we call hungry gut, where you feel hungry right away after you eat a meal, these medications, they tend to work very well. But if the patient's having more behavioral challenges, where there's like not burning as much energy, or maybe they are having more hungry brain and eating disorder, then if you don't address the root cause of that, the medication may not necessarily work. At the end of the day, weight loss is in the kitchen. Weight loss happens when you reduce the caloric intake. It's not necessarily happening because you are increasing the physical activity or even from taking a medication. You need to have a little bit of what we call negative caloric balance, right? You need your caloric consumption, how much calories you spend per day. That depends on your muscle mass. So some people have like V4 engine or V6 engine, right? So how much muscle, if you have a lot of muscle mass, you spend a lot of energy, even if you are sitting. But then also energy expenditure is related to how much energy you spend from exercise and being physically active. We call that physical activity, and not the exercise, the physical activity, NEAT, non-activity related thermogenesis. It's not like non-exercise related thermogenesis. The amount of energy you burn just from being physically active, from parking the car far away, from maybe standing rather than sitting, when you do the editing for your podcasts, right? Or
fidget, as we used to call it, fidgeting.
Yes.
I'm a fidgeter. I can't, I don't sit still.
That by itself helps, right?
Yeah.
You spend more energy.
Yeah. That's interesting. That's the energy expenditure.
So you need a comprehensive approach. You need to think about this not just from like a medication standpoint. This is the definition of obesity medicine. So we discussed the definition of obesity, but obesity medicine is the science of taking care of patients with obesity using pharmacotherapy, which is medications, lifestyle interventions, which include physical activity / exercise, and meal planning. But the most important thing is teasing out the root cause of issues. Why did the weight gain happen? What complications are we dealing with? Is the patient having pain? Is the patient suffering from sleep apnea? Because sleep apnea, for example, it can cause weight gain. So if you take
why would that be?
Because it actually increases the kind of some stress hormones and markers that can actually result in worsening of insulin resistance. Again, what we know about obesity and the weight is nothing but the tip of the iceberg. There are a lot of things we don't know. I would be lying to you, Stephanie, if I tell you, I got this. I know 100% of that. No, I don't. What we know is just the tip of the iceberg. Why? Because we are at least 100 years late in addressing this as a disease. Because me in medical school and even other medical students here in the US, we do not get enough training about nutrition, about obesity, about energy expenditure, and all of these topics we have been talking about today.
It sounds like, Naser, that in order to deal with obesity, you really have to almost like know about every area of medicine. I mean, it's, most of us just think it's straight on. You just deal with the weight and the reason, the simpler reasons for gaining the weight. I had no idea it was this complicated.
Absolutely. And that's why actually we have hired a physician who's joining the team next month. And his background, I made sure that his background is not, I'm an endocrinologist, right? Mm-hmm. His background is primary care. Because obesity medicine is nothing but, being a super internist. taking care of the patient as a whole.
So how do we've talked about the drugs, we've talked about the fact that some people are just not under our current situation are going to be able to use them who that perhaps could be helped by them. And we've talked about lifestyle. I would say the last thing that I would want to talk about is how do we make the small changes that could lead to big changes? Something as simple, for example, if you fall beneath the poverty level and you get cash help from the government to buy your food. There was a big discussion some years back when some people wanted to say, well, you can only use that money for healthy food, like greens and vegetables and lean cuts of meat and so on. You can't buy potato chips with it. And then somebody pointed out that in the poverty areas of the cities, for example, the grocery stores don't have fresh vegetables. They don't have fresh green stuff because it's expensive and because there isn't a demand for it. So the two together. So it doesn't exist. So you can't say, well, you can't use the money to buy anything else because they got to buy something and that green stuff isn't there. I don't know how it works exactly today, but I venture to guess that you don't want to stigmatize people and say that person over there, because they're earning their own money, can buy potato chips, and you, because we're subsidizing you, can't.
Yeah.
So I imagine they can still buy potato chips. How do you deal with that kind of a problem, for example?
It's hard, right? But to answer your question, number one, education, right? So we need to learn more. Like we need to educate the communities rather than expecting like this approach is passive. Where like, okay, take the money, like buy whatever you want, right? Have them own the problem, but at the same time provide them resources at a young age where, okay, you can make the choice. And this is my opinion. Number two, compounding, right? These interventions for weight loss are very similar to 401k. It's about the small contribution you make every day in your health. How many steps you walk every day? How many parks do we have in that neighborhood to encourage physical activity? Are we dedicating a lot of time to actually teach these communities about physical activity, exercise, wellness, right? Are we making sure that we keep them engaged, motivated, activated as communities, rather than being passive and thinking about, okay, let's spend this money on actually teaching them how to be good investors, to be
it's kind of like teaching people how to control their lives in a sense.
100%. This is about controlling your life,
at least the part you can control,
rather than exactly. This is about mindset.
Yeah.
Not about the weight on the scale, believe me.
Yeah.
This is about being in control of your health, of your life, of your well-being, of your community, about being a positive contributor to the environment that surrounds you.
Shouldn't that be part of the school system then? Because again, I'm coming back to these obese kids. And they get to the point where they can't do the kind of sports you do in most schools, because physically they're not able to.
Yes.
Shouldn't we start with that kind of education in like kindergarten and first grade?
We definitely have to do something. We have the highest prevalence of obesity worldwide,
right,
in the United States. Something is obviously wrong.
Right.
There is something that's wrong. This is like if there is a country that has resources and money, it's the United States. But if there is a country that has a major issue with the prevalence of obesity, we have sick kids. We have to make a serious change. This is a big challenge. This is much worse than, COVID-19 pandemic. Remember how many changes, policies, laws, how many rules we broke, or we thought like this is like the norm of doing this, like you shake hands with someone, or wearing a mask is insulting to people. Now it became normal, right? Just
Yeah, except that think of the backlash to those rules.
Mhm.
I just spent some time in Florida, and I think I saw one person with a mask on, and she was probably in her 80s. It, I just am afraid that if we start trying to do this in the schools properly, which I agree with you, that there is going to be some kind of backlash. If it's not done properly, if it comes out as a rule or a regulation or something that you must do, because that seems to be what happened with COVID. We told people you have to do something and you can't do something else. And
Yeah.
people went crazy. And and they're still, you know, just don't tell me what to do. And so when you say think of the rules that we made, yeah, they worked in terms of the first year, and after that we started having the backlash
Yeah.
because we're Americans and we are not used to being told what to do. How do we deal with that?
I think there has to be graduality. There has to be wisdom, and there has to be a comprehensive plan. We have to look at the big picture, the low-hanging fruit. This is not about, controlling what everyone's diet like. This is about making sure our kids have the understanding, but most importantly, have the motivation and the knowledge about how important it is to be well. This is about quality of life. This is not just about longevity. This is not about, the weight on the scale. This is about feeling, as I mentioned, and you mentioned, that control is the illusion of control. If you feel you are in control of your health, if you feel after a total knee replacement, you can go back and walk, and actually not just walk, run, not just run, carry weights, right? Or if you feel that after a total knee replacement, you can barely walk and you're stuck with that cane, you will always have that cane. Same thing for the weight. Same thing for physical activity. Whether you feel you can make a difference or not, you are right. I always tell my patients that. Whether you feel you can take your health and well-being to the next level, you are right. If you feel you cannot lose the weight, if you feel we cannot, change the activities, we will not be able to do that. We have to start somewhere.
All right. I think we probably covered a lot more than we had expected to cover because this material is so important. Can you think of something else that you would want to say?
I just want to say that we are blessed here in America. We have a lot of resources. We have a lot of blessings. And we are, in a way, paying the tax of convenience. That's why we're suffering from that epidemic of obesity. And it's time. Yes, it is a little bit late, but it's time. We just need to be open-minded. We need to look at the big picture, and we need to implement some strategies to make a difference. But I really want to thank you, Stephanie, for having that good understanding, for actually spreading awareness about the topic. I think yes, physicians can make a difference, but believe it or not, podcasts and the news have been had an instrumental role in bringing that difference, because it goes to a mass scale, and patients with obesity may not necessarily volunteer the information we have been talking about. We have to stand for them and talk about the topic and have an honest conversation. So thank you for inviting me today, and I'm looking forward to making that change, one podcast at a time and one patient at a time. Thank you.
And I want it done now. I don't have your patience. And thank you so much for coming on the podcast and talking so honestly about this.
Thank you so much.
Dr. Naser Gharaibeh heads the Valley Health System Center for Weight and Wellness in New Jersey. He is board certified in obesity medicine, as well as in endocrinology, diabetes, metabolism, and internal medicine. Links in the show notes on my website and wherever you get your podcasts. Have you ever gotten hit by a huge medical bill when you thought your health insurance was going to pay for most of it? Do you know that unpaid medical bills are one of the top reasons Americans declare personal bankruptcy? In our next podcast, that's episode 31, I'm talking to Frank Laub. Now, he's written 3 books about how you, your health insurance, your doctor or hospital, and U.S. law interact, and how you can navigate through the jargon and secrecy to protect yourself and your family. There's a link to Frank's newest book, The Big Lie in My Healthcare Bill, in the show notes. Look for episode 31 to drop on the 3rd Tuesday of March, since I schedule one new podcast a month. I'd really appreciate it if you would subscribe and share. We're on Apple, YouTube Music, Spotify, TuneIn, Amazon Music, iHeart, Podchaser, and my host platform, the Podbeam app. The video version is on YouTube. Show notes and links on my website, www.stephanieshelton.com/conversations. I'm Stephanie Shelton, and until we meet again, take care of yourself and all those you love, and I'll see you next time. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.